Dr. Schütz's research focuses on clinical interventions and health service in substance use disorders and dual diagnoses with mental health disorders. He's interested in the neurobiological and neurocognitive aspects of impulsive decision-making to improve treatment of addiction and concurrent disorders. Dr. Schütz is also the medical manager at the Burnaby Center for Mental Health and Addiction, focused on treating individuals with severe concurrent disorders. Dr. Schütz, welcome, and I'll pass it over to you now.
Thank you very much. I've tried to see if I can share my screen and get the... Can you see my slides?
Yes, perfect.
Okay, thank you very much. I had a little problem getting into the session. That's why I'm happy to be here. Thank you for the introduction, Elena. And I do think we have a lot of time because I did keep the presentation relatively short, so feel free to ask questions. And what I want to talk about is psilocybin treatment of alcohol use disorder. We are starting, to be honest, the acquisition soon. We have the first patient starting in January, but it was a long journey to get there to really conduct this study. And I'm happy to share some of the experience on how we got there. But before I get started, I would like to acknowledge that I do have some potential conflict of interests, a number of funding agencies, and I'm also on a research advisory board. One of it is ClearMind, which is a startup doing preclinical work for alcohol use disorder. What I want to talk about today is first provide some historic notes, some of the development, talk a little bit about the pharmacology, and then the current status of the treatment and where we stand. And I'm happy to answer comments and questions. I'm not completely sure if I should do it at the end. I'm actually happy if that's possible to have questions in between. So feel free to send questions, and maybe after each section we can also kind of start with questions. If not, I'm also fine with having them at the end. First of all, psilocybin was first developed in Basel in Switzerland by Albert Hofmann. Albert Hofmann works at Sandoz, and he kind of like identified psilocybin as the active ingredient in the magic mushroom. Actually 20 years after he had developed LSD. He's most known for his work in 1983 or 1938 or 39, I'm not sure, developing LSD accidentally. And but he's also the one who did psilocybin. Actually, it was 38 that he developed the LSD. The histories of LSD, which is much older than research on psilocybin, is interesting in that it actually really started in England. It really started in Canada. Humphrey Osmond was a psychiatrist from England who took on a position in Saskatchewan, Canada. And in that hospital, he actually started treating alcohol use disorder patients with LSD. And he did that for the longest time, and this was very innovative at the time. And he presented a few years after he had started the treatment with a new term for the treatment, and he called it like manifestation of the soul or the spirit or the psycho, the psych part. He wanted a new, fresh term to describe the effect of the substance, the psychedelic effect, as he called it, and it has stuck and has been really had a renaissance within the last 20 years. I only wanted to very shortly go into the historic notes and talk more about the current concept. I found the historic notes important in the sense that actually the psychedelic treatment was started with alcohol use disorder. And so that is something where we are only now getting back to. When you look at the effect of the substances, you can have here three groups. One is the ketamine group, so to say, the MDMA group, and the psychedelic group. And what you can see is that psilocybin does act on serotonergic receptors, as do LSD and DMT. The effect on the different receptors is similar in the three substances, but not identical. Actually, most of the research so far has been with psilocybin and LSD. DMT, there has been very little research so far, but I will assume that over time, research will increase simply because DMT, the psychedelic experience is much shorter than psilocybin and LSD. And it turns out that the length of the effect of the psychedelic experience is a problem in the sense that you need the participant to be supervised and to be in the hands of professionals during that time. With psilocybin, that's generally like around 6 hours, for example. With LSD, if anything, it's longer, like 8 hours. And with DMT, we are talking more about like 2-3 hours. So the shortness of DMT might be an advantage in the future, but currently there's little research being done. LSD and psilocybin is really on the forefront. I'm not going to go too much into MDMA, which have different mechanism, and ketamine, but I just want to mention that one reason why we are probably now doing more psychedelic treatment is because ketamine was a success story. Ketamine was also developed, I think, in the 60s, 62 actually, and only recently was it approved as a treatment for major depressive disorder. I think that opened a lot of doors, and the interest of a substance which used to have been mainly recognized or acknowledged as a substance with potential abuse capacity, but now turns out to most likely have quite substantial treatment effects. The effect of psilocybin is often really focused around the serotonergic 2A receptors. Mescaline, psilocybin, LSD all have the 2A receptor affinity, as do they have also serotonergic 1A affinity, which is the receptor which is made responsible for the antidepressant effect of the SSRIs. When you compare the SSRIs and the psychedelic medications, then they seem to be the main focus of the action seem to be in different areas. In the SSRIs are mainly working their effect over the limbic stress circuitry, while the 2A serotonergic receptors are more in the cortical region. And that has led to the hypothesis that it probably is a different effect, and it might be a complementary effect in that SSRI reduce the stress and anxiety and potentially also impulsivity and aggression, while the impact on of the psychedelic medication is more on rigid thinking. So what is the hypothesis is that the SSRIs increase the or help with overcoming the emotional blunting and increase resilience, while the psychedelic 2A receptors are made more responsible, or the interaction with the receptors are made more responsible for a greater involvement of the emotions and the environmental sensitivity. The hypothesis, and it's still a hypothesis, the evidence is interpreted by different groups quite differently, is that psychedelic allows to what might be kind of summarized as the rigidity. So it allows to go into new directions, and it allows to make new connections in the brain, and to change, so to say, the trajectory. What is here is the entropic brain activity that's based on a recently very important concept on how the brain works. And what the data may show, that's an interpretation of the data, is that the psychedelic do allow high entropy, which what actually means it increases the chaos. And increasing the chaos means that you lower the rigidity and you allow, so to say, for reconnection and redirection. One aspect which is discussed in the field is, do you need the psychedelic effect to have the a hope for outcome? And currently, most researchers would probably agree, given the data, that you do need the psychedelic effect, so to say, the psychedelic experience, in order to have the full therapeutic impact. This is seen different in the field of ketamine, where, for example, the psychedelic effect, if you want to, or dissociative effect, seems to be not as important. Again, the field is very young. Research studies generally are not as well powered as you would hope, and results are need to kind of like continue to show in the same direction. That would indicate that actually psychedelic experience is necessary. That's the hypothesis at the moment. Let's move on to the current status of the development of the treatment of alcohol use disorder. First, I want to show some data why I think alcohol use disorder is important. This is data from 2014 of Canada, and what it shows is actually the worst public health impact, namely the mortality of different substances of abuse. And what you can see here is that in alcohol, there were at that year about 15,000 deaths attributed to the use of alcohol, 50,000 to the use of tobacco, 800 to the use of cannabis. Opiates at that year were 2,300. Nowadays, we talk, I think, about 6,500. So it has more than doubled since then. And one interesting thing is that when you look at other drugs, there is some other drugs, and looking at psychedelic, there is no death associated with psychedelic. With ketamine, the estimated number of deaths associated to ketamine is probably 3 if you take the US data where you have 30. So it's really low abuse potential overall. And the question with psychedelic is if there is even the potency that they become addictive. So it's in principle a very safe drug. When people kind of hear the numbers, for example, tobacco 50,000, the question comes: when is the average age of death? So how much reduction do you have of life expectancy? And what you can see here is actually with alcohol, it's about 16, 17 years. With opiates, it's much higher. And potential years of life lost it's still the legal drugs which is driving the process. And for example, when you look at opiates, even if it doubles, we are not yet getting to the level of alcohol potential years of life lost. I just put the numbers at that year, 2014 overall deaths. There were 260,000, about 4,000 suicides, about 1,000 of them included alcohol use, and the average age of expectancy at that year was 82. So I think focusing on alcohol is worthwhile simply because it is still a major driver of public health problems. One concern, which is always with if substances which are potentially abused are also used as medication, is that they might induce a psychosis. And these are data from Finland, where, let me actually go here, data from Finland, where they looked at substance-induced psychosis. And when you look at the overall number, which is here, alcohol, again, is the substance which has by far the most substance-induced psychosis, namely 50,000. They have very little numbers, 125 have cannabis-induced psychosis. Amphetamine is the second highest. And if you look at hallucinogens, very few of them. And then the question is, how many of them convert later on into a diagnosis of schizophrenia? Again, the highest number is with alcohol use disorder, surprisingly. Amphetamine is high, and if you look at the overall number, the probability, if you have substance-induced psychosis with cannabis, the highest. There is some similar risk between sedatives, which would be benzodiazepines, opiates, hallucinogens, and amphetamines. And alcohol, actually, the transition to a diagnosis of schizophrenia is very low, even though it is, in Finland at least, the number one for the transition to from substance-induced psychosis to schizophrenia. So the numbers are very small, and the risk is, for example, similar to, for example, the risk of benzodiazepines. When doing currently studies using hallucinogens, mainly psilocybin, people have been very careful because they are concerned about the psychosis risk. And what you can see is that the published studies actually have been selecting participants quite extensively. So only 6 out of the 1,000 patients screened were included in this study, and it's even less so in the Griffith study. So there's an intensive screening currently happening in published studies on individuals who participate in these studies. This is different, for example, in other studies where these two here, you have little screening, probably generally you have higher screening than that, but this is unusually high selection of individuals. And these are the studies which have been published, clinical trials on psilocybin. So what you can see here is there are 2 studies on alcohol. Can you see my cursor? Yeah, so I should have asked earlier, actually. This is the more recently studied, most recent publication from Schütz with alcohol use disorder. He had an earlier publication with a small number of participants 7 years ago. There was one study using tobacco use disorder, and there's a number of studies who have looked at major depressive disorder, general anxiety disorder, and OCD. When we focus on the alcohol use disorder, there's actually 2 studies so far published. One is the Schütz, really the big study with 95 participants. 25, they provided individuals with 2 sessions of psilocybin. In the first 25 milligrams, In the second one, the participant could choose to take the same dose or a higher dose. And then the earlier study had been a little bit lower dosing. Similar doses were actually used for the tobacco use disorder study. Overall, 25 milligram of psilocybin have almost become something of a standard. And we in our application generally do not increase the psilocybin dose, but some other groups have been doing that. Here's the control. The first study didn't have a control. The second had an antihistamine, diphenhydramine. That is a issue which is discussed a lot currently because it's very hard to develop a true placebo for the treatment, because the psychedelic experience is very important. So that has been discussed as a major issue, and also has been identified by the health authorities as an issue for getting the medication or getting the substance accepted as a treatment, because a true placebo-controlled trial is difficult. There were no dropouts in this study, and they had follow-ups in the two studies around half a year. And what they showed was the treatment was, in both cases, there were no severe side effects. So that is something which is a finding which has been quite consistent, that side effects are minimal. But keep in mind, there's also a very selected population. That might change if the population is not as selected. And they did show a significant reduction in the heavy drinking days, and actually increase in the number of abstinence. They did report that the control drug failed to blind. And that one problem was also in the study that they, in the follow-up, people did miss the objective assessment of abstinence. So, but these are very, let me see, these are the graphs. Percent heavy drinking days over the week, 36 weeks. And what you can see is that the effect is significant, but even the placebo effect is fairly strong in this study. That obviously there is a need to continue to study and to see how you can optimize the effect and optimize the interaction also between the psychedelic treatment and the psychotherapy, which is also something which is discussed currently, how to optimize the setup of the study. One issue which has been discussed, I think, consistently is that the intervention overall is quite expensive, because you do need a lot of psychotherapeutic support for the studies. And that has been a concern for me. One of the big advantages of these studies is that it is an opportunity to go back to the drawing board and do see how we better coordinate and integrate medication and psychotherapeutic approaches. That is something in psychiatry which has been limited. Generally, medication and psychotherapeutic approaches are just seen as add-ons, and they are rarely coordinated, while in these studies there is a preparation phase, there is a phase during the psychedelic experience, and then there's an integration phase afterwards, where you work on optimizing the effect of the intervention or the effect of the psychedelic treatment, and combine it with psychotherapy.